Okay? Describing pain.
Okay.
Okay.
Good. So I'm going to tell you what chapters you need to read for midterm quiz, okay?
Okay.
And I will upload everything and together with presentation, and we have 3 more lectures before midterm quiz, okay? Today we're going to talk about describing pain and the importance of descriptors, okay? Let's start. Let me share my presentation. Just a moment.
Good afternoon.
Good afternoon. Hello.
Doctor, you are in the clinic?
Yes, yes.
Doctor, for the midterm, we should discuss the presentation and the book, or only the presentations?
No, not presentation. You can also read. Main information in presentation is from the book, and you should read the chapters, okay? I will write down which chapters you should read. Just a moment, I'm on a call, okay? Just a moment, I'm sorry.
Take your time.
Just a moment, I'll turn off my phone.
No problem, doctor. Take your time.
Thank you. So, no, it's not. So, can you all see the presentation?
Yeah.
Yes, very good.
Yes.
So, and again, one more time, it's very important to remember that to ask right questions and analyze the responses correctly. Yes, we remember, everybody remembers this, right? So let's talk. So this is the slide, which chapters you should read and which chapters you need to know for midterm quiz, okay? Please note this. This is chapters from 2 to 11, and from another book, Lars Anderson, Oral and Maxillofacial Surgery, chapter 5. It's about local anesthesia, okay? We'll talk about local anesthesia in next lectures. So for today, as I mentioned many times, you should ask right questions, then listen, and you should analyze the responses. Correct.
1 second.
Yes.
I just want to take a picture.
Sorry?
I just want to take a picture of the chapters, please.
Just
Why?
a moment. Here. I'll write down this also. Here, please.
It's fine, thank you.
You're welcome. So, what sort of pain are you having? This is also very important question. Yes, will elicit a variety of responses. Some patients can describe the pain accurately, where others have difficulty putting words to their experience. Okay, pain descriptions are influenced not only by particular pain, but also by level of an arousal of the brainstem prior to the pain experience. The patient's emotional state and language, idiosyncrasies, and ethnically determined behaviors. It's also very important to listen correctly and to ask the right questions. Pain descriptors are also affected by the intensity and type of pain being experienced. With recent advances in functional brain imaging, the complexity and plasticity of the brain, along with its anatomical and functional reorganization in the presence of chronic pain, are being subjected to more sophisticated and intensive investigation. there is a beginning recognition that central plasticity is an important feature of a chronic pain experience. So what is neuroplasticity? You should know this. If not, please note this. Neuroplasticity or brain plasticity is the ability of the brain to modify its connections or rewire itself. Without this ability, any brain, not just the human brain, would be unable to develop from infancy through to adulthood or recover from brain injury. What makes the brain special is that, unlike a computer, for example, it processes sensory and motor signals in parallel. It has many neural pathways that can replicate in other functions, so that small errors in development or temporary loss of function through damage can be easily corrected by rerouting signals along a different pathway. So please, it's very important. Remember these words. What is neuroplasticity, okay, of the brain? The question, do you have any reaction to heat or cold, is closely linked with what sort of pain are you having, and should be asked early on. As an affirmative answer, almost always identify the pain as being of dental origin and immediately prompt the clinician to move laterally along the diagnostic tree to screen for a dental cause. Rarely do other medical conditions have a trigger in the teeth, although maxillary sinusitis, trigeminal neuralgia, or pretrigeminal neuralgia may present in this way. The descriptors used by patients with these medical conditions are, however, usually different and distinctive. So, diagnosing orofacial pain is made easier if clinicians routinely use sorting or screening questions and utilize a diagnostic tree to suggest further questionings and investigations. It's the responses to screening questions that direct the order and selection of the specific screening questions. It is the responses that help to confirm or deny a possible diagnosis and suggest useful testing methods. Screening questions for an orofacial pain diagnosis have been grouped into 7 broad groups, as you see on the slide. The manner in which screening questions are asked may vary from clinician to clinician according to personal preference and personality, but for orofacial pain, initial screening should include the following. This is basic information gathering. How may I help you? What do you think is the cause of your pain? And you should listen, okay? Pain description. What sort of pain are you having? Do you have pain to heat, cold, or sweet? The site of pain. Where is the pain? Can you put your finger exactly on where the pain is? Time analysis. When did the pain start? Where did the pain start? Factors influencing also the pain, okay? Psychological and lifestyle factors. Does anything make pain worse, for example? Does anything make the pain better? Does medication help to relieve the pain? Psychological, as I told you, okay? Associated general symptoms. Does anything else happen when you are in pain? These are these main questions what you should ask and gather information that may help you to make the right diagnosis. Now let's talk about severity of the pain, okay? Patients will usually describe the pain, the type of pain they are experiencing, and give an indication of the severity of the pain. Patients indicate severity both verbally and non-verbally. The information provided on severity should be recorded in patient's words. Unfortunately, there is no infallible way of measuring pain or feeling what patient is feeling. A visual analog scale It is VAS, where a patient rates pain using a scale from 0 to 10 or other similar numerical scale. Is therefore helpful in assessing the patient's personal interpretation of the severity of what they are experiencing. In the VAS, the 0 represents no pain and 10 is the worst pain the patient can imagine. This helps the practitioner to determine the urgency of treatment intervention. For chronic pain, for example, patient's baseline VAS assessment is also helpful to the clinician for assessing a patient's response to treatment over time. For example, it is not uncommon for chronic pain patients to report that they are not getting any better, whereas reference to the VAS shows, in fact, that their pain experiences are diminishing in intensity or frequency. Okay, now let's talk about descriptors. When describing pain, it's necessary to be aware that patients will use descriptors that are often very specific for different pain states. Thus, when taking a pain history, it's imperative to record the exact words what patient uses in describing his or her pain. Even if one of many assessment forms that are available for recording pain histories is used, exact descriptors should be recorded at the time of examination. Although the descriptors used and the manner in which the patient describes the severity of the pain may seem unimportant at the time, this information often proves invaluable when reviewing the diagnosing and recording changes in the pain profile over time. As well as recording pain descriptors, it is helpful when taking a pain history to also draw a representation of the time of pain the patient is reporting using a line diagram. Pattern and intensity recording in relation to a linear timeline. The height of the line indicates intensity and the shape of the line indicates the pattern of the pain experienced. Adding the construct of time under the diagram completes the diagrammatic representation. This type of recording is particularly helpful in complex diagnostic situations, especially for case of recall when a patient returns after an absence. In addition to recording the word descriptions the patient uses, line drawings can be used to characterize the type and severity of pain. Constant mild pain, constant severe pain, stimulated pain, prolonged stimulated pain, pulsating pain, and pain that have a daily pattern, clusters, or random initiation trigeminal neuralgia can all be illustrated diagrammatically. These diagrams can be referred to later when confirming a diagnosis. Similarly, many other pain conditions follow patterns that can be represented diagrammatically. From a practical point of view, it is much easier to recall a diagram when reviewing a patient's file than trying to read through a set of written notes. A pain diary can be useful when assessing patients with chronic pain. Any changes in pain throughout the day, such as its intensity, triggers, and patterns, can be recorded. This is especially important when assessing the effect of medication. For most patients, it is important that the diary only be kept for short periods of time and, if possible, placed in the patient's record so that they do not rely on to remind them they are in pain. Importance of descriptors in diagnosis of orofacial pain. Patients usually describe pain using sensory descriptors, the type of pain, However, descriptors can also be effective or evaluative about the pain. Yes, patients can also use diagnostic terms for pain. What they think, for example, it is. There are useful questionnaires that describe the importance of descriptors. The Magellan's pain questionnaire, for example, was designed to provide a quantitative measure of clinical pain that could be analyzed statistically. Okay, it lists over about 70 or 80 descriptive words divided into 20 different categories that a patient can use to describe pain. Applies the numerical value to each pain descriptor, thus allowing the progress of a patient to be monitored over time. Not all patients can describe their symptoms eloquently by the words. Descriptors a patient uses are very significant and often suggest a diagnosis or a line of questioning. It's important not only to hear words, but also to interpret the meaning of these descriptors. When a patient has a difficulty describing pain, take care not to suggest specific descriptors. Instead, ask the patient to use any and as many words they feel are appropriate. Some descriptors are specifically related to specific pain state, while others are informative for the type of pain and its effects are applicable to dental pain and should raise a flag when used. Thus, when listening to a patient's description, it's important not only to hear the descriptor, but also to analyze what the descriptor means. What does that mean? What else do I need to know? For example, when a patient reports, now talk about this. For example, when a patient reports sensitivity to sweets, a natural reaction of most clinicians is to jump to a clinical diagnosis. However, pain to sweetness is a very specific descriptor. Okay, what does that mean? It indicates three things mainly. The patient has a dental problem, the tooth is vital, the dentin is exposed. Okay, what else do I need to know now? The tooth is vital, so sensitivity testing of all teeth in the area is not indicated. A similar analysis. Okay, what does that mean? What else do I need to know should be made each time a descriptor is used. Descriptors in the Magellan's pain questionnaire are arranged in groups: sensory, affective, evaluative, and general. The following compilation of descriptors are adapted from those in the Magellan questionnaire, but with other descriptors also added. Now let's talk about sensory descriptors. That can be sensory descriptors are important and explain how the pain feels to the patient. There are a large number of these. However, not all are specific for dental pain. More common descriptors of dental pain are highlighted in italics, if you see on my slide. Okay, I wanted to write in different script that you should definite. Sensory descriptors can be, for example, time related. For example, flickering, quivering, pulsing, throbbing, beating and pounding. And also movement or space related, jumping, flashing, shooting, electric, jolting. Every patient describes pain differently. Describing a puncturing sensation, for example, pricking, boring, drilling, stabbing. There are very many words to describe this kind of sensory pain. Describing a cutting sensation, sharp, cutting, lacerating, splitting. Describe a constricting sensation, pinching, pressing, describing pulling sensation, pulling or wrenching, perceived thermal sensations, for example, hot, burning, scaling, searing, cold, freezing. It's everything. Every word describes this sensory pain, type of pain, okay? The non-acute pain, for example, dull, sore, hurting, aching, tender, unpleasant. Describe acute pain, for example, agonizing, dreadful, terrible, severe, piercing, very bad. Describing presence, the constant, intermittent, sometimes, always. Sensory pain descriptors can also be broadly categorized as bright, sharp, and superficial, or dull, less severe, and more deeply seated. Pain can also be described as spreading, where the pain spreads slowly over the broad area, or radiating, or where the pain spreads rapidly to another side, for example. Or facial pain can also be referred to another side, as happens in dental and muscular pains, or can migrate from side to side, as is common in trigeminal neuropathic or facial pain. A second group of words describing pain are affective descriptors. Unlike sensory descriptors, these terms describe how the pain affects the patient. Patient can state how the pain makes them feel directly: sick, nauseated, fearful, frightened, frustrated, or communicate the same information by using descriptors. Special care has to be taken when managing patients who use effective descriptors that may have psychological basis. These patients may have a concomitant psychological problem. A third group of descriptors are termed evaluative. These tend to indicate the intensity of pain. For example, descriptors: annoying, troublesome, chronic, miserable, intense, and unbearable. The descriptors the patient uses are extremely important when diagnosing orofacial pain. Special attention needs to be paid to them. As mentioned above, some of these descriptors are specific for dental pain, but others are not. For example, the words dull and constant used together commonly indicates muscle pain or occasionally sinusitis. Itching is often a descriptor for soft tissue or periodontal conditions. Waves may be a descriptor for pulpitis. Throbbing, pressure, sharp, hurting, sore, aching, stabbing are common dental descriptors. Other descriptors, such as punishing, cruel, or vicious, are more likely to be psychological descriptors. What the pain is doing to the patient. Special notice should be placed on the use of descriptors that are usually not used for describing dental pain. Descriptors including flashing, burning, jolting, movement, and electric shock-like feeling fit into this category. These descriptors are more likely to indicate a neurological cause. Some descriptors need qualification. The word constant and severe, constant and dull, constantly there. Okay? Some descriptors are cause and effect. If these happens, then happens that these terms are helpful to assessing stimulated pain. Some descriptors are colloquial and specific to communities, countries, or ethnic groups. They can vary from one group to another and may need local interpretation. It should be apparent from the above that patients can use a myriad of descriptors to describe orofacial pain. Assessing the meaning of descriptors and the patterns in which they are expressed provides a roadmap leading to an accurate diagnosis. Carefully listening to and recording descriptors used by the patient and then analyzing reasons for these responses are essential because many pain conditions exhibit patterns of symptoms that are mirrored in these descriptors. Pay particularly attention when the manner in which the patient describes the pain and the descriptors they use do not add up. The descriptors should fit the diagnosis. Okay. Early in the questioning of the patient, it's necessary to establish the site of the pain. It's important to appreciate that patients can only report where they think the pain is. This location may not be the actual source of the pain. Pain can be referred from a distant source. Nevertheless, patients must be given an opportunity to describe both in words and by physical demonstration where they think the pain is located. When trying to establish the site of pain, two questions you should ask are, where the pain is, can you place your finger on where the pain is? Okay. Today I will describe the importance of asking a patient to physically describe where the pain is, rather than having them just tell you where it is. It is often helpful to record the pain diagnosis profile and location of the pain diagrammatically, both intraorally and extraorally, in the notes or by drawing pain locations at the same time, for example. This provides valuable documentation for later. So let's start with placing, for example, a fingernail vertically between two teeth. If a patient describes the location of pain by placing a fingernail vertically between two teeth, as you see on the slide, the action means that the pain is localized. It doesn't establish where the discomfort is tooth or soft tissue related. Look initially for food infection, then press on the interdental papilla with the back of the probe. Then ask, is this the type of pain you are feeling? If the patient answers affirmatively, a soft tissue origin is highly likely. Cracked teeth and loose restorations can also be described in this way, but can be differentiated from soft tissue pain by pressing on the soft tissues and describing as I described you above, okay? Moving, for example, also moving a fingernail on a tooth. If a patient demonstrates pain by scratching or moving a fingernail over a tooth surface, this indicates that the pain is localized, tooth-related, and can be provoked. Look initially for exposed dentin by scratching the tooth surface with a probe to try to reproduce the pain. Okay. Also, placing a finger over the apex of the tooth. Patients who describe pain by pressing over the apex of the tooth are demonstrating pain that is localized and usually of soft tissue origin. The position of the finger of the apex, over the apex suggests that periapical pathology may be present. Another possibility is an ulcer. Okay. Pressing on the gingival margin. If a patient indicates the pain is coming from the gingival margin, the pain is localized and probably of soft tissue origin. The position of the finger indicates that the pain is likely related to the periodontal inflammation rather than to periapical pathology. Check initially for a periodontal abscess or a vertical root fracture. Rubbing now, rubbing a finger rapidly back and forth across the touched gingiva. There is the difference between the patient pressing on the gingiva while moving a finger slowly versus rubbing a finger rapidly back and forth across the soft tissue. Some patients may report soft tissue sensitivity that has a neuropathic or sensory nerve origin. Occasionally, these patients describe the pain by moving a finger rapidly over the small segment of gingival margin or dental papilla. The gingiva can be red and shiny due to the constant rubbing of a finger or the tongue over the side. If a soft tissue origin is confirmed and various local measures do not provide relief, the careful application of capsaicin cream, for example, like Zostrix, may provide relief. Holding one tooth. Patients can verbally describe toothache while at the same time holding and moving an individual tooth. This action indicates that their pain is localized, tooth-related, and involves the supporting tissues. The subject tooth should be tested for vitality, percussion sensitivity, and mobility. In the absence of obvious periapical involvement, check for periodontal problems, history of trauma, occlusal trauma, or vertical root fracture. Patients who hold firmly onto a tooth after cold stimulation to warm the tooth are experiencing localized dental pain. Be very careful if the descriptors used by the patient seem unusual and cannot be explained. Trigeminal neuropathic or facial pain, and even some malignancies, for example, maxillary adenocystic carcinoma, can present in this manner, and be very careful, okay? Holding or moving several teeth. Pain elicited by the movement of several teeth together or independently indicates the pain is from supporting tissues and not from individual tooth. There also may be pain to percussion. In the absence of frank periapical infection, this is not tooth pain. If there is a history of trauma, check for an alveolar fracture or fracture of the facial plate or bone. Pulp extirpation will not relieve this sort of pain or any pain to percussion. Now touching the side of the face, holding or moving several teeth. Yes, and touching, that describe this kind of pain, touching the side of the pain. Much can be learned by the way a patient touches the side of the face when describing the localization of pain. On the many anatomical structures present in the orofacial region, including the skin, parotid gland, muscles, blood vessels, and facial and trigeminal nerves, any of them can be responsible for pain. A patient can indicate the localization of pain on the side of the face in different positions and different ways. Some patients are unable to locate pain to any specific area and may just cradle their face. Unfortunately, most patients gesture with their hands and fingers in a distinctive manner that is helpful from a diagnostic point of view. For example, where and how the patient demonstrates pain by pressing on the side of the face, the number of fingers used, and the manner in which they are applied to the face have great significance. For example, as you see on this slide, for example, picture A, tenderness beside the nose, tenderness just lateral to the ala of the nose, is likely to be soft tissue pain related to periapical inflammation from axillary, canine, or lateral incisor. Other soft tissue pathologies need to be considered. Now, for example, picture B, tenderness immediately under the eye. Tenderness to palpation immediately under the eye is the area of the infraorbital foramen. Is often associated with maxillary sinusitis. Thus, screening for this possibility is indicated. Now, picture C, tenderness on the lateral borders of the zygomatic arch above the second premolar. Tenderness on the lateral border of the zygomatic arch immediately above the maxillary second premolar or first molar tooth suggests involvement of the anterior attachment of the masseter muscle. Confirm this by placing a finger firmly on the area of tenderness and then asking the patient to clench. Increased tenderness during clenching will confirm masseter muscle involvement. Okay, now picture D is a tenderness in front of the ear. Pressing one or two fingers on the face immediately anterior to the tragus of the ear suggests arthralgia. Just a moment. Of the temporomandibular joint, especially if the fingers are moved in a circular motion and the patient moves their jaw. Okay, pressing under the maxilla is the absence of obvious dental infection or other pathology. Pressing under the maxilla. Patients who describe pain by pressing in the middle of the face just under the maxilla are often describing masticatory muscle pain. This is particularly diagnostic if they move their fingers in a rotary motion. If pharotic pathology is responsible, the area of tenderness will be located more posteriorly and the gland will be palpable. Important question to ask when developing a differential diagnosis or trying to explain this finding to a patient are: is it painful if you press anywhere on the side of the pain? Can you make it hard if you press the side of the face? Note that a patient can be assured of a non-dental origin by having them press into the body of the masseter and then clenching. Ask them whether the pain they are experiencing is the one they had experienced previously. Pain to palpation during clenching confirms a non-dental origin. Note that masticatory muscle pain can develop secondarily to other painful conditions and may become the main complaint. Therefore, a thorough investigation is required to exclude other causes. Now, pressing on the body of the mandible with fingers in motion. If a patient describes pain by pressing on the side of their face with several fingers moving in a circular palpation motion, they are probably massaging the masseter muscle. The patient needs to be screened for muscle pain, especially if the movement is associated with the movement of the jaw, moving fingers in line under the mandible. A common complaint of patients with muscle spasm is that their glands swell up under their jaw. This is demonstrated by massaging the submandibular area with several fingers in motion and in line with the lower border of the mandible. These patients may have been prescribed several courses of antibiotics and may report the pain disappears over time, only to return days or weeks later. Patients who describe pain in this manner are likely to be describing pain associated with the posterior digastric muscle and should be screened for joint and muscle dysfunction. Ask How long does it take for the antibiotics to work? If it's more than few days, the relief likely to be from the passage of time rather than from antibiotics. Okay? If fingers are in motion when describing pain, the likelihood of dental origin is diminished. When the patient moves their fingers independently to one another, pain is likely to be dental origin. Patients who massage under the mandible with their fingers in line are usually palpating suprahyoid muscles, usually the posterior belly of the gastric muscle, and are describing pain from muscle dysfunctions. Salivary gland pathology rarely represents as just submandibular tenderness. When the tenderness does occur, it's usually intermittent and occurs shortly before or during eating. When a patient describes pain for a lymph node, it's usually demonstrated with a single thumb or finger or by picking up the gland between the thumb and finger in a more defined gesture. Describing pain on all lower teeth by running a finger around the gingival margin in the absence of front periapical or periodontal pathology. Patients who complain that their gums are sore or describe their pain by running their finger around the alveolar mucosa and gingiva are describing pain associated with clenching. They often complain that the site of pain is situated halfway up the gum. Note that of particular diagnostic importance is that a finger across the midline where the cause of the pain is being demonstrated. If a finger of hand used to describe the orofacial pain crosses the midline, a non-dental problem is almost always the cause. Now describing pain with two hands. Patients with sinusitis, tension, headaches, muscle pain, and TMD may describe the location of pain using both hands. The pain is bilateral and symmetrical. Screen for muscle pain and sinusitis. If the pain is unilateral, check to see if the actions of describing the pain follow normal anatomical structures or pathways, okay? This will help in developing a differential diagnosis. If the pain is bilateral and symmetrical, consider anatomical explanations, but screen for neuropathic or facial pain and psychological factors. Although rare, also consider the possibility that two unrelated causes exist for the pain. Note, be aware that some patients with persistent idiopathic facial pain use exaggerated two-handed gestures, which may be inconsistent with normal anatomy to describe the distributions of their pain. Where two-handed descriptions of pain are not consistent with normal anatomy, screen for psychosomatic factors. Consider referring the patient for assessment by a specialist. Okay? Now talk about bilateral pain. Once a patient states that their pain is bilateral, all the rules change because the pain is invariably not dental in origin. When investigating bilateral pain, consider the anatomic distribution of pain and whether the pain is symmetrically situated on each side of the head. The three most common causes of bilateral pain are muscle dysfunction, including referral of pain from neck and shoulders, and temporomandibular joint arthralgia, sinusitis, maxilla, neuropathic trigeminal or orofacial pain, Bilateral or facial pain from other causes is rare. Central lesions rarely produce bilateral pain. Bilateral trigeminal neuralgia can occur, but it's very uncommon, and the pain on each side is distinct and separate and may not involve the same division of the nerve on each side. Primary tumors or metastatic disease very rarely cause bilateral or facial symptoms. In these rare instances, they are usually accompanied by other signs. In every pain diagnosis, always ask, do you get or have your head pain on the other side? If a patient responds positively or with a statement such as yes, occasionally, but mostly it's not, and it's only this side, it is indicative of a non-dental problem. Note, bilateral pain is almost always non-dental pain, unless the cause of pain is in the midline. Percussion pain on multiple teeth. In the absence of obvious periapical pathology, patients with pain on percussion of multiple teeth should be screened for clenching or occlusal trauma. A dental cause is highly unlikely. In the maxillary sinus pathology has to be considered. Remember, however, that responses to percussions vary from patient to patient. What to some patients is a gentle tap on the tooth is to others a severe blow. In order to assess pain on percussion, the response of the tooth is, the response of the tooth in question should be compared to responses obtained from adjacent teeth and corresponding tooth on the contralateral side. It is not sufficient to tap on the tooth and ask, does this hurt? Almost always the answer will be yes. It is best to access responses to percussion testing by comparing them to the response from other teeth. After the first cycle of percussion testing, repeat the testing in different order. Some patients with trigeminal neuropathic facial pain or persistent idiopathic facial pain exhibit an exaggerated response to almost any stimulus. This makes an assessment of where teeth are actually sensitive to percussion very difficult. In a small number of patients, percussion testing is not reliable, although the response to percussion must be resist or questioned when multiple teeth are sensitive. Multiple tooth sensitivity can occur. As above, in the maxilla, this can be due to a maxillary sinusitis. If teeth in both jaws are involved at the same time, screen for a clenching habit. Note, removal of a pulpectomy from a vital anterior tooth will not relieve pain to biting or percussion unless the tooth is fractured or cracked. Holding the hand on the side of the face. Most patients who describe the location of their pain by placing a hand on the side of their face or cradling their jaws or face with a hand are unable to localize the source of pain. Okay, an appreciation of severity of the pain can often be assessed by observing the facial expression and manner in which the patient drops their chin into their hand. The manner in which they cradle their face may indicate the severity of the pain. If the pain is deep and severe, dental pain from an acute pulpitis is suspected. Other patients may be describing muscle pain. Note whether the hand is moving when the pain is described. If so, the possibility of dental cause is diminished. If they report relief by placing their hand on the side of their face, are most likely describing muscle pain, and they should be screened for this. Questions to ask are, is the pain relieved by a hot shower or hot pack? Can you make the pain worse by pressing on side of your face? Similarly, if a patient reports relief from pain from a hot shower or a hot pack, then screen for muscle pain. Although a hot shower can provide some relief from the pain of sinusitis, there are usually other associated signs and symptoms with this condition. Complaining of inability to sleep on one side of the face, in the absence of frank periapical or other overt infections, unilateral maxillary sinusitis, if a patient reports that they cannot sleep on one side of their face, suspect muscle dysfunction, particularly masseter muscle spasm. Now, thus, one of the screening questions for muscle pain is, does it hurt to sleep on that side of your face? Now pointing to the area but reluctant to touch it. Patients suffering from trigeminal neuralgia can variously describe their pain experienced. Trigger points can be present. Some patients may report that touching the trigger point sends shooting pain up the face or along the jaw, along one or more divisions of the trigeminal nerve. Although most patients are reluctant to touch the trigger point, others may very likely touch the trigger to show its position. They also may map out the distribution of pain with one of their fingers and state, if I touch here, the pain shoots up here. Some patients may use the other hand to show the distribution of the shooting pain once the trigger is activated. It's fairly obvious when pain from trigeminal neuralgia occurs. The patient often stops talking, the face may twitch, and the eye may close slightly on the affected side. Some patients with trigeminal neuralgia insist that pain is from a tooth. If a patient insists that the pain is dental, ask them to swallow with their teeth apart or touch the trigger point without touching any teeth. For example, lifting the lip may help to confirm for the patient that the pain is not dental. Any patient who describes shooting electric shock type pains should be asked the screening questions for trigeminal neuralgia. Other neuralgias also need to be considered. Okay, complaining of altered sensation, numbness, anesthesia, and altered sensation, paresthesia, can occur as a symptom when mandibular premolar teeth and mandibular first molars are acutely infected. Be alert, however, for orofacial pain that is associated with altered sensations where no dental cause can be found. Although bacterial and viral infections are often implicated, the possibility of nerve damage, systematic disease, or an intracranial lesions need to be also considered. Numbness or anesthesia can occur in Bell's palsy, which resolves in 6 to 8 weeks, and with a rare viral condition involving the mental nerve. Patients often indicate an area of an altered sensation by rubbing or patting the affected area. When an area of lost or altered sensation is noted, the area should be mapped with blunt probe. Then the area should be drawn on diagram or even marked directly on a patient's face and photographed like this on slide. This enables the changes in distribution of the new numbness to be followed and documented. An increasing area of numbness is of concern and requires referral. Altered sensation can be a sign of an pending herpes zoster attack or Bell's palsy, then when seen in conjunction with motor disturbances or altered sensation in other areas of the body, for example, hands or feet, a differential diagnosis that includes multiple sclerosis and other neurological problems must be considered, and referral is required. Note that a patient may describe local areas of altered sensation by putting the side of the face or moving their fingers rapidly over the skin surface, describing pain in and around the eye. Around the eye. Pain in and around the eye can be caused.
Doctor, you are reviewing every chapters now?
Sorry? I'm sorry?
What chapter are you reviewing now?
I'm reviewing chapters, combining chapters 5, 6, and some, I guess
11?
5 or 6. No, not 11. Chapter 11 will be next lecture. Next lecture, okay?
Okay, great.
You know what? I have changed the topics because now we are talking about commonly questions, and we have discussed previously. Yes, pain on heat, pain on. Sorry.
Doctor, I was asking if the pain around the eye.
Yes. I'm talking about.
Can the patient complain it by phone, or he must go to the doctor?
Sorry, can be caused by a number of conditions. There are many conditions that patient describes pain around the eye. For example, migraine headache, sinus conditions, including ethmoid sinusitis, eye problems, trauma, cluster headaches, and there are many variety of possibilities when patient is describing
Doctor?
around the eye.
When we finish, you will send us this PPT on WhatsApp?
Sorry, I couldn't understand you.
When we finish, you will send us this PPT?
This presentation, yes, if you wish, but this is from the chapters you should read from the first book.
Okay.
Okay?
Okay.
No, let's talk about the pain, about what around the eye, right? Who describes, now when assessing the patient who describes pain in or around the eye, you're tired? I have not been. Just, I guess we need 10 or more minutes, not much time, okay?
Okay, doctor.
Okay. When assessing the patient who describes pain in or around the eye, note any previous history of the complaint and association signs and symptoms, especially any visual disturbances. Migraine headaches often occur behind the eye and can involve blurring of vision of the presence of the aura. Most patients are aware of migraine. Cluster headaches is usually associated also with ptosis and meiosis. Headache pain and visual disturbances may be a sign of giant cell arteritis. Carotid dissection must be considered when there is an initial episode of several eye pain with concomitant Honor syndrome. There are many different causes the patient may describe to pain around the eye. Urgent referrals is critical for any patient when the cause of pain that occurs in or around the eye, along with any visual disturbances, cannot be quickly determined. Okay, describing pain between the eyes Patient with frontal or ethmoid sinus conditions can present with pain between eyes. It's common, however, for pain from sternocleidomastoid muscle to also be referred to this side. Okay, pain between the eyes. Remember, pain between the eyes is not of dental origin. This information is what we need. Okay, now describing pain around the what we're going to talk about at the base of the skull. No, I wanted to describe pain in around the eye, in around the eye and around the base of the skull. What I wanted to talk about. No. Okay, so if a patient presents for facial pain diagnosis, but also states that bilateral pain is presented around the base of the skull or in a band around the head, screen for tension, headache, and muscle dysfunction. If the pain is unilateral, screen for cervicogenic pain, neck or shoulder problems, and postural problems common in the workplace. Carefully observe when a patient describes their pain as to whether the hand or fingers stray from the distribution of trigeminal nerve. Note also where the hand movement is associated with movements of the neck or jaw. Except for acute infections, these patients are unlikely to be describing pain of dental origin. Remember, however, that the auriculotemporal branch of the mandibular division of the trigeminal nerve supplies sensory innervation around and behind the ear, and that is common from mandibular molar tooth pain to be referred to this area. Dental pain is always referred to a branch of the maxillary or mandibular division of the trigeminal nerve. Where patient pain description involves sites outside the distribution of this nerve, the complaint is rarely of dental origin. Okay, patient may develop facial muscle pain as a secondary problem due to the stress of underlying dental or non-dental problem. The muscle pain can then become the patient's chief complaint. Treatment of the facial muscle pain may need to occur first before an accurate diagnosis of the underlying problem can be made. Patients with chronic medical conditions such as chronic fatigue often develop secondary facial muscle and joint pain. In diagnosing orofacial pain, it is as important to watch the body language of the patient and observe how they physically demonstrate where the pain is, as well as having them verbally tell you where it is. Often, the manner in which patients physically describe their pain governs the screening questions and testing that will be used to establish the right diagnosis. Now, that's all that I wanted to talk about for today. Okay. Let me see, for next lecture, sixth lecture, it will be sixth lecture, we'll discuss the rest chapters from this book, and after that we are going to discuss local anesthesia and local anesthetics, okay? And after 8 lectures, we'll have the midterm quiz. And for the next lecture, before we start discussing local anesthesia, we will take more time for these questions. I will prepare.
Doctor, can you please tell us what to focus on the midterm?
What book? This book. These two books you need for this midterm.
Yes, the exam will come like from the book, not other than the book, cases related. From the book, the exam will come, yes?
From the book. Questions will be all from the book, okay?
Okay, thank you very much.
I just want wanted to make some presentations to talk not only from the book, but also from the practical view, and that's why I made these presentations. But questions will be from these books and from these chapters.
Doctor, can you show us your clinic?
Sorry?
Can you show us your clinic, please?
I'm sorry, what clinic? What are you asking about?
Can you show us behind you your clinic?
Yes. Can you see? Can you see? This is my microscope.
Yes, it's very beautiful.
Here. Here. This is my room. So, just a moment. So everything